Well, hi, everybody. Meg here. Thanks for joining. I was just saying, expected that we'd have several folks who either had conflicts today or needed to join virtually. So wanted to give a few extra minutes. We also just heard that part of the turnpike is closed. So we may have a few other late joiners from the advisory council. But given that I haven't heard from anybody, I just wanted to get us started in a timely manner. I might just do one check. If any of the members who are joining virtually, Kate, Jenny, or Jeff, if you could just confirm for me that you can hear us before we get too deep in.
This is Jenny. I can hear you.
Okay, wonderful. Thank you. Trying to take learnings from some of our prior meetings where we jumped right into the agenda, only to find out we were having technical difficulties. So thanks everyone for being here. I think I will just briefly do attendance for the folks that are on. And we can do introductions for the board members, starting with those who are in the room. So Katie, sorry to put you on the spot right away, but would you mind kicking us off?
Good afternoon, Katie Fulham-Harris with Maine Health.
You, Jordan.
Hey, Jordan Rhodes with Maine DHHS.
Thanks very much. Jenny, would you mind going next?
Sure. Jenny Boyden with Department of Administrative and Financial Services.
Thank you. Jeff?
Jeff Sanford, VP of Finance at Northern Light Health.
Thank you, Kate. Hey, Andy, just double checking. Are you able to come off mute? No worries, but we see that you're on there. We can circle back later. And I know that Trevor is on via phone. He let me know he'd be joining a little bit later, so I won't ask him to introduce because I think he may be driving, but he'll be joining us in a little bit. And a couple other members, like I said, who had let me know they weren't able to join, but we may be seeing a few more virtually soon. With that, I'll jump in, and I wanted to actually start with a non-agenda item, but an exciting announcement, which is that the team at the Office of Affordable Healthcare has grown again. Wanted to welcome Kaylee Shea, who has joined the team just a couple weeks ago, also still quite new. Kaylee grew up in Portsmouth, New Hampshire, so not a Maine native, but very, very close. And went to Colorado College, where she studied political science, and is coming and joining us from Consumers for Affordable Healthcare, where she's been a policy advocate for the last few years. So Kaylee's role will be a little bit different than Katie's. She'll be helping more with sort of broad policy research, and especially with work with the legislature. Those of us who do that work know that there's lots going on during the session, and so having an extra set of hands to help with tracking bills and keeping up with everything as it's moving will be really, really appreciated. So just wanted to welcome Kaylee to the team and introduce her to everybody. Great. So then jumping into the agenda, wanted to start off today, as we promised at the last meeting, by going over some public hearing comments. We just had the public hearing when we had our last advisory council meeting, and we're actually still accepting written comments. So this is an opportunity to do a little bit more of a in-depth kind of walkthrough in the level of detail that we plan to incorporate into the annual report. Wanted to touch on the outline for the annual report as well, and then lead that into a conversation about these policy focus areas that we've discussed in the past two meetings, and thinking about how we can incorporate a little bit of a forward look towards the end of that annual report, and talk about where we want to have our focus in the next year. I can't believe 2025 is right around the corner. So moving into the comment summary, and a big thank you to Kaylee. One of the things she helped with in coming on board was aggregating all of this and displaying it for everyone. Just an overview of the types of commenters. Used a similar process to kind of categorize commenters as we did for the last public hearing, but given the registration process that we used this year, we were actually able to have people kind of self-identify into these groups, which was helpful. I think the distribution is directionally pretty similar to last year. We did have some more individual comments. I think having a website this year when we were putting the hearing together helped a lot, making it a little bit more accessible for individuals to submit comment. Fewer comments from hospitals and health systems than in prior years. So that was one note. And then a few more advocacy organizations, including a couple national groups that commented, but otherwise a fairly similar kind of breakout of the individuals who commented. And just a quick note about kind of the breakout of different professional groups here, because this is always one of the tricky things. For insurance and for hospitals, we kind of included the associations representing those entities in those categories because we did feel like there's a very clear membership relationship there. The provider category we specifically use just for folks who are independent providers, folks saying, I am a doctor and here is my experience with patients. And then we included Maine Medical Association in the association, I think, category that kind of was other entities in the healthcare space that sort of didn't fit directly into one of those two other categories.
And can I just to make sure I heard you correctly, this represents the people who testified at the public hearing, but not necessarily written comments?
No, I'm sorry, I should have clarified this. This is a combination of the two.
Okay, but you're still accepting written comments?
No, I'm sorry, we were last meeting. I should
Oh,
have been
last,
clear. I was
okay,
saying-
sorry, I missed
We
that.
had the
Okay,
public
that makes more,
hearing,
I was like,
But
wait
we
a
were
minute.
still accepting, so that's why at the last meeting, we only briefly
Got it.
touched on the hearing.
Got it.
But yeah, this is the combination of the two, and we had lots of folks who spoke in person and then submitted a written comment, but we only counted them once.
Okay, thanks.
No, thank you, I'm sorry, I should have been clear about that. So moving into general themes, again, always difficult with lots of comments from lots of perspectives to draw these out. But there were a couple that I'd call out as being similar to last year. That would be the rurality element, came up a lot across the board. That Maine is different in that sense and some of the unique challenges presented by a small population that's very dispersed. And then I think the high cost of living, maybe with a little bit more emphasis on inflation this year, but the fact that sort of intersects with healthcare costs and can make healthcare costs even more challenging for families and for providers too. A couple things that I think were a little different, a little bit more discussion of hospital and provider consolidation this time around, particularly I think on the advocacy side and from the carriers. And then I can't remember last year, actually, now that I say it, but I think I noticed a little bit more of a focus maybe on Maine Care rate reform. So not so much just Maine Care reimbursement, but I think given all the work on rate reform this past year, a few different perspectives on that kind of cropped up in the comments. So moving into individuals, our biggest category, a few different reflections or themes from this, and I'll just briefly pause here to say we used a similar sort of process as we did for prior years of kind of looking where there were two or more comments in a category to decide what we'd pull out as themes, with the exception that we did have one category that was just one commenter this time, so we just reflected their comments. So what we saw in terms of sort of barriers and challenges, no surprise, I think most consistent feedback was just struggling with premiums, deductibles, and out-of-pocket costs. And had several stories from consumers this year talking specifically about times when they had skipped care or delayed getting care because they were concerned about the cost that they would face if they did. I think it was maybe more of a theme, but we had fewer comments last year, but still a little bit of that concern, less about total cost maybe and more unexpected nature or sort of lack of understanding of what they were being billed for and concern about that. Some about difficulty navigating insurance systems, and in particular, I think we had a couple individuals who had been covered by Maine Care, and through the process of unwinding of Maine Care, were needing to seek out their own coverage, and either found that confusing, or we're talking about the drastic difference in cost to them going over to a marketplace plan and the challenges associated with that. And then, somewhat relatedly, kind of complexity of Maine Care eligibility determinations, people who maybe didn't understand why they hadn't been previously eligible, why they weren't eligible now when they had been, and just trouble kind of navigating that application and determination process. Not a lot in the way of policy recommendations in these comments. I think, not unexpectedly, most of them were more talk about challenges and personal experiences, but I do think we had a couple that said we really should have a single payer system to.
Question, was there any, obviously when premiums would represent commercial plans, but was there any sense of Medicare or MA plans being part of the comment, sort of people on those plans being commenting as well? Because that seems really important.
Yeah, that's a good question. I don't recall if any of the comments specifically mentioned that to you.
I think the individuals that commented on Maine Care were talking about eligibility determinations and weren't necessarily talking about premiums.
Yeah, I think
Relationship.
thinking for Medicare versus
Okay, yeah.
like
No.
PSI or individual, in general.
When you say no, they were not on Medicare, or there was not a break, that we don't know what they were on?
we don't know what they were.
Yeah, okay.
But I'll double check and I can get back to
Yeah, no, I wouldn't be surprised. The reason I ask is because anecdotally, I'm hearing a lot more from like our patient service reps about Medicare, people who have Medicare Advantage in particular, having lots of surprise bills, but it's not related to sort of the commercial or what this
Yeah.
group is doing. So that's why I was curious.
Yeah, I will say my recollection from reading through is at least a few of them made references that I think, about my coverage through my employer, more focused that made me think they were, commercially insured.
Yeah.
But there were some that didn't, that could have fallen into either category.
Thanks.
Yeah, it's a good flag. I definitely think that's a theme we've heard about. So moving on to the advocacy category, given that this one was really broad and a little bit of a catch-all, we thought that we would just include a quick overview of who was in this. So a couple of different sort of national advocacy organizations, several organizations representing either consumers or businesses in here, a couple whose mission is particularly kind of advocating on behalf of immigrants or refugees. And then we put employer purchaser representatives in here as well. So just it is a broad category. Just want to acknowledge that one of the harder ones probably to try to summarize. I should have mentioned at the beginning as well that also thanks to Kaylee, all of the comments in full are posted on the website now. So anyone who'd like to go and actually look through, there are several that are lengthy, so a lot more detail than what we could capture in this summary. That being said, in the advocacy category, again, I think surprise, high premiums, deductibles, and out-of-pocket costs, as well as high cost of prescription drugs, given, I think, both representation of consumers and businesses in this category were flagged. A handful of comments in here spoke about hospital consolidation, the impact of consolidation on prices for hospital services and challenges presented there. Also some discussion of eligibility gaps based on immigration status, and finally discussion of medical debt. So I think, all themes again that we've heard at prior public hearings as well. So I think the recommendations, track pretty closely to those issues. We heard last year and again this year about those Maine care eligibility requirements, transparency and access to free care, which was obviously an issue and discussed during the last legislative session, was a theme in some of the comments as well. We did have a few comments about universal health care or public option plans, again, kind of advocating for that expansion of government coverage to more people or in some cases to everyone. Finding ways to address the high prices for hospital services that were mentioned, and finally limitations on facility fees. Again, which I think tracks to work that was done during the prior session. I know I'm breezing through. If anyone who is joining virtually would like me to pause, or if you have questions or comments, please just let me know.
Just for the record, the limit on facility fees exists. So again, that's where I go to the Medicare. That's where we hear a lot more of the complaints, and that's a whole different. So, yeah.
So for independent providers, that feedback, I would say several with, compelling sort of examples or observations, again, of their own patients delaying care due to cost. Had examples of folks who weren't filling prescriptions or had declined to have, relatively minor procedures done. And interestingly, a couple of the comments specifically spoke about transportation in rural areas, both from the sort of expected perspective of hard to get to medical appointments, but also one spoke a little bit about just gas is really expensive and car maintenance is expensive. And that as an example of probably the impact of those inflations and overall rising costs, that increasingly they felt like they were hearing more from their patients about making trade-off decisions between other sort of costs of just living and their health care. Not so many detailed policy recommendations in this section. I think like individuals, it was more about sharing their perspective and urging action rather than sort of making specific policy recommendations. But a couple did reference sort of price transparency and more visibility into prices for consumers and for themselves. And several, didn't have specific strategies, but said something really needs to be done about these out-of-pocket costs and premiums. Probably with a bit more emphasis on deductible and out-of-pocket costs there, since that's what's so visible to them in terms of accessing care prescriptions. Moving on to association participation, again, I just wanted to kind of like define this. So Primary Care Association, the Maine Medical Association, and the Pharmaceutical Care Management Association, which represents PBMs, were the three entities that were captured in this category. So again, some variation in interest here for sure. So for barriers or challenges here, once again, high premiums, deductibles, out-of-pocket costs, but I think in particular, the Primary Care Association very directly, and I think the Medical Association via their policy statement, which was referenced in their comments, discussed kind of underinvestment in primary care and a need to restructure the system to better support primary care. So for policy recommendations, a little all over the place here, skipping back and forth between the two, but accelerating value-based care for patients particularly. I think that was a focus of the Primary Care Association. I do think we put in, though I don't know that those two folks spoke specifically to it, but from PCMA, you know, thinking about patent abuse and generic and biosimilar competition, when thinking about the drug pricing issue, and yeah, the primary payment reform specifically to advocate for or advance primary care, excuse me. More to go. We'll do hospitals, health systems, and then insurers. So hospitals and health systems were where we just had one comment from Northern Light Health this year. So this is reflective just of their comments. Like last year, I think they discussed the challenges of the pandemic and sort of the resulting cascading impacts on infrastructure and their workforce in particular, spoke about challenges with reimbursement rates for government coverage programs, so Medicare and Medicaid. And then speaking again, as I know Lisa did last year, about the challenges of kind of the continuum of care, and that in many cases there are individuals who maybe shouldn't be in a hospital setting but are because there's not an appropriate setting to discharge them to. And I think the policy recommendation we pulled out from there was, you know, looking for higher reimbursement from Maine Care to support hospitals. For insurers, we had a couple individual insurers and then the Maine Association of Health Plans oh, sorry, let me pause because I see you have your hand up, Mallory. Did you want to weigh in before I move on?
Yeah, just to, on that last slide, you know, I think that last bullet point of the barriers, the broken continuum of care, you know, having worked within, you know, looking at the sort of the mental health, behavioral health side of things, I know that that's a huge piece and continues to be a huge piece in the broken continuum of care, leaving many people in the hospitals and overwhelmed. I see the policy recommendation to increase payments to hospitals, but conversely, the problem is in the continuum of care in the community. And you know, I know we've got the whole rate reform process and everything, but it is still not working. And so, you know, policy recommendation really has to be to look at Maine care payments across the continuum of care in the community to be able to step people down from hospitals. I just don't want to lose that piece in this. I think it needs to be a second bullet there.
Yeah.
Thank you, Mallory.
Yeah, well said. Thank you. Mallory, and definitely, I think we were trying to be reflective of the comments, and we could take a look back and see if, you know, we should generalize based on what Lisa wrote, or if that was us, you know, projecting onto that one. But hear you too, but yeah, we're just in these ones at least trying to capture but understand that perspective for sure.
Yeah.
Two things can sometimes be in a little bit of tension. So moving on to the insurer comments, definitely, I think the strongest theme was probably speaking about concentration of provider networks and hospital systems in the state and challenges that presents in terms of negotiation for price and network breadth. The high cost of specialty drugs was called out, which is certainly something I've heard from purchasers, as well as in recent years, you know, a major driver and obviously something that's very top of mind for folks right now. And then anti-competitive contract terms were called out in at least two of the comments, I think, here. So, you know, provisions like anti-tiering, anti-steering in contracts with providers. So for policy recommendations, this is, I think, similar to last year, prohibiting those kinds of contract provisions, increasing state review of hospital and provider consolidation was recommended. preserving utilization management tools. I know often conversation in the legislature around prior authorization, formulary placement, and really advocating for the use of those tools in controlling cost. And then noting that coverage mandates should undergo study with cost impacts considered. Again, something that I think has been the focus of a lot of attention in the legislature the last couple of years. I think that is, our final one. So I will pause there for a minute and see if there's any other kind of comments or reflection, just reiterating maybe that I think, not in this exact format, we'll probably try and put it into paragraph form a little bit, but essentially this is kind of the feedback that will be reflected in our annual report section that summarizes the public comment, which is one of the things we're required to include in that report each year.
Nothing surprising.
Yeah, I don't think there's anything that comes as a shock at all. I agree.
I think the time of year, for some reason this year, like I didn't note that there Mallory was in transition at that point in time. I'm not sure if they submitted comments, but I know like I didn't get to submit comments. I think Jeff didn't get to submit comments. So the timing this year was just not your doing, but just it was tough for a lot of reasons. So there just are gaps in this that I think would otherwise be filled.
Yeah, understood. And I think it's one component of the report, I guess I'd say. And we do just kind of work with what we get, but
Absolutely, yeah, that's all
I
you
think
can
we
do.
try to be pretty transparent. We'll think about exactly how to do this, but like we did with showing who's part of a category, because again, very difficult to find a way to do this that captures some nuance, but it's high level a lot enough. So
You've done a great job.
Yes.
So,
but we will make sure that we're not representing comments as this is the universal view of all hospitals. But thank you. Very briefly, we don't have a formal summary of this yet, but happy to share it. But did want to just give an update because I know I discussed it at a high level again at our last meeting. We did end up being able to pull together some kind of community conversations, we call them, to kind of supplement this process of the formal public hearing. So we did those in the last week of October, and we had some support from United States of Care, which is a national organization that kind of specializes in thinking about how to bring consumer voices into healthcare decision making. So they helped with logistics and allowing us to feed people dinner, which was really nice. And we held one gathering up in Machias where we had 13 participants. We had another in Lewiston where we had 21, a huge turnout. We had to close the list in Lewiston because we had a lot of people wanting to come. And then we worked with Trevor and his team at the Healthcare Purchasers Alliance to kind of co-host one meeting outside Portland focused on business owners. So we'll be working to kind of bring together high level and some pull-out quotes from those, but I think at a high level, certainly, especially from the consumer meetings, very mostly similar to this, certainly leading with, frustration about premiums and out-of-pocket costs. A little bit more conversation about kind of quality of care and empathy of providers in those conversations, particularly up in Machias, which was interesting. And then another big theme was access. So lots of conversation about like difficulty. Mallory, to your point, lots of focus, especially in Machias, around behavioral health care. And then in both settings, primary care and sort of difficulty just getting an appointment outside of an ER setting when there's a healthcare need. So not, shocking things there, but it was really great to sit and actually they were very conversational. So people were talking back and forth with each other about their experiences. And it was nice to be able to do that again, because we know that this format can be hard to ask people to come and sort of give a speech or present formal comments. So we're working on, putting together some kind of 1-2 pagers that summarize the finding from those that we'll share and publicize as part of the annual report.
that will be really helpful. I'm curious, 2 questions. Lewiston, did you have some similar themes or different themes in Lewiston, given all that's happening there?
I would say yes. Less, a little bit, focusing both on behavioral health care, but maybe more acute or a bigger focus in the Machias group. Yeah. I think more focus in Lewiston on the out-of-pocket costs and a little bit more on the insurance side as opposed to the accessing care side. That's one difference, I would say. A little bit more conversation about cultural competency in Lewiston and struggles and advantages. Some folks there, both sides of the coin there. But yeah, there was some conversation, especially when we were there towards the end of October, but about some of the kind of mental health support structures put in place there as a result of the shooting that they had, but also conversation about how those were focused like just on that event and support and like lack of ability to kind of transition into more ongoing support. So yeah, lots of differences. It was interesting. And I will say more of the conversation about kind of like quality of care, comfort interacting with care in the Machias conversation.
Yeah, that's interesting. And then on the provider one, any takeaways?
Did I say it was business?
Sorry, business, yes, no, definitely.
Yeah, that one was really interesting too. We had a variety of different sized organizations. So we had some that were buying, just had employees going to the individual market, many fully insured and a good sizable chunk who were self-insured. So variety of perspectives because of that, because some are much more sort of in the weeds on their claims data. But I think, just talking about the challenges that they've all had. I mean, I think across the board, increasing spending on their healthcare, whatever the model is, has been a challenge, and talk about like what that's meant in terms of trade-offs for them, in terms of hiring, wage increases, sort of the way that they're thinking about that. We talked a little bit about drivers, drugs came up for sure, and then hospital prices came up as well, and talked about like opportunities and challenges with things like new, models or encouraging centers of excellence or different care models, and the difficulty in like actually encouraging their members to think about price or think about quality when they're kind of shopping around or going for services. Thanks. That's all off the top of my head, so probably more.
No,
That's a concept.
that's okay.
It was a really great experience, so really grateful to United States of Care too, who helped make that possible and doable. So yeah, more to come on that. Anything else in terms of Terry? Great. So moving along, I know this is very high level, but I did just want to touch on the annual report outline. I will say a lot of this is drafted, but there are some additional kind of work products that we need to incorporate that are external to us, including an updated expenditures report from MHDO. But my goal is by the end of next week to try to send a draft around to members of the advisory council, so there can be sort of a week before the holiday when folks can take a look and send us comments if you'd like to before we try to wrap that up. So be on the lookout for that. But like I said, I wanted to talk about it high level just as a setup to the next part of the conversation in this meeting. So really briefly, probably no big surprise, we just want to do an intro and kind of an update on our operations with the big exciting news to share with legislators that we filled out all of our positions now with the three of us. We'll review our kind of analytics plan that we've presented to this group in the past and the work products that have come out this year. So nothing new there, just kind of essentially talking through the same presentation that Katie shared during the public hearing of walking through the dashboards and what that means, the report from the Urban Institute on coverage and household costs, and then that expenditures report, which we actually referenced in last year's annual report, but is just undergoing an update now. We'll do the public hearing comment summary and then our summary learnings from the consumer and business learning sessions. And then where I'd like to kind of close out the report is talking about these focus areas for 2025. And like I said, this is the conversation we'll move into, but it's why I wanted to talk to the advisory council about it now and sort of get input before we lock this in. But really trying to get to a place where we have these domains of policy where for the immediate future, we can kind of get into a deep dive. So this isn't saying we're recommending action necessarily in these areas, even if it's action, not necessarily legislation. It's really more just about these are the places where we've identified that we think there's opportunity for policy to make a difference, where we think there's not folks kind of in the state already working heavily in this space, and where we think there's a path forward that's kind of feasible. Happy to take questions, but it's a good lead into this slide where I just kind of reviewed our conversation from last or 2 months ago's meeting, October's meeting, where we talked through the domains in August, kind of came back and used this this lens of these three different categories: alignment, feasibility, and opportunity. And I think at the end of that meeting, I sort of indicated that there were three that I was thinking about as being the greatest areas of opportunity. I did make an edit here in light of Jeff's feedback to tone down the feasibility on aligning incentives for efficiency a little bit if I was being a little overly optimistic there. So that's orange in this version. But wanted to spend some time talking through what that looks like and what that means in my mind. And then I also have a slide towards the end because I know we talked about workforce potentially belonging here. So wanted to have more of a conversation about that. So that's the next part of the agenda, but maybe I'll pause there if anyone has questions just about either the high level overview of the annual report or revisiting this conversation from October. Okay, great. So the first of those three domains that we talked about, I actually made an edit as I thought more about kind of a problem statement here and next steps. It had previously, we characterized it as constraining prices. And I changed that to regulating commercial prices for healthcare services because as you'll see in the problem statement, I think I'm trying to think about two competing but maybe related challenges here. The first being that I think both in the data that we looked at from the hospital service and utilization dashboards and in feedback that we hear from purchasers and via rate review from carriers, that commercial prices for healthcare services, and I'd say specifically, we hear a lot about hospitals, but I don't think that's the only set of services, are a driver of those insurance premiums and out-of-pocket costs that consumers are struggling so much with. And barrier for consumers in accessing care and a real challenge from an economic perspective as well. But want to sort of balance that with understanding that we also hear pretty consistently from providers and the public too about this difficulty in accessing care, particularly primary care and behavioral health services, those services being under sort of supported and underinvested in, and some of the difficulties like recruiting and retaining, particularly sort of higher level patient care staff.
And lower level. It's actually the whole span.
Everybody, yeah.
Yeah, I mean, CNAs are almost as difficult.
So I think that that's, a theme, and it's one that I frankly sort of feel from the legislature of how can both these things be true? How can the system be struggling? Meanwhile, prices are a challenge too. Hi, Kevin. Thanks for joining. So that's sort of the problem statement that I wanted to use to further build out when we have kind of this title. What do I mean by it in terms of a scope of work? Is that's the challenge, and how do we move forward in better understanding that challenge and thinking about solutions for it. So I have some next steps there, but Jeff, I saw that you have your hand up, so I'll pause there.
Yeah, no, thanks, Meg. So I certainly appreciate, and this is a difficult one, right? Because, and you've tried to capture, I think, the issues here, but as I look at that last statement, which is totally true, right? Very difficult, finding, staff at all levels. But it's also the cost of virtually everything just going up, like out of people's control, right? Not only is it difficult to recruit, but we're recruiting at higher rates, right? The cost of staff is increasing, the cost of supplies is increasing, at rates we had never seen before. And so, hopefully that's cooling off, but the fact of the matter is, during, the inflationary periods, our costs are going up double what our rate increases from, our major payers are going up. I mean, it's just not sustainable for the providers.
Yep, understood.
I guess if I could add to that, I don't have a problem with the problem statement as it's drafted here, but it is, I think, and maybe Jeff, this is what you were getting at, but it's a segment. So what it is a problem statement. It represents a piece of a much larger picture or a much larger puzzle, really. And it doesn't address, for example, the gap between Medicare and Medicaid payments and how that impacts commercial payments. So, or commercial prices, sorry. So I think that just it feels important for the problem statement maybe to be a little bit larger in reflecting the bigger picture. And then I understand that you can't do everything at once. So honing it down, to say we will start by focusing on this piece. But absent that bigger picture that represents, yes, it represents cost of labor, to Jeff's point, cost of supply, and gap between increasing population. We're the oldest state in the nation. One of the highest percentages of patients on Medicare. Medicare pays 80 cents on the dollar. That has to be reflected in there too. And we have 22% of our population on Medicaid that pays 7 cents or less on the dollar. So just making sure that somebody who's reading this who doesn't understand the big picture doesn't take away that commercial prices for healthcare services are being driven solely by providers raising prices sort of in a vacuum.
Yeah. I was just thinking about how to reflect that without sort of both your comments, Katie and Jeff, without a laundry list, get to your point about, and not wanting to necessarily in this problem statement draw causation conclusions, if that makes sense, because I think part of the work in the next steps is to move towards that. I think that saying maybe something along the lines of, given lack of control or involvement in or ability to influence, maybe that's the right terminology, public payer reimbursement rates, that there is a need to focus on commercial rates in order to support services.
I mean, I'm confident that you will come up with something, but I guess or even broader, saying there are a multitude of factors that drive increased costs. And we know that one piece of that is commercial prices being driven by, you're making a causation statement by saying that commercial prices for healthcare services are a driver of insurance premiums. Now, I think that's nobody's going to necessarily argue with that, but there is a causation statement there. So
true. Yeah, I think that's fair. I guess what I will say is I was not necessarily drawing a connection, though I understand why, like you said, for somebody just reading it. So I will give some thought to this between trying to say, and therefore, prices are going up and therefore it's recruiting and retaining physicians, for example. That's the challenge that's causing that either. I think I was really trying to think, like I said, because initially I was approaching this from purely a price is the challenge perspective. And I think a lot of states are thinking more about constraint. What I was trying to get at with the second sentence here was an acknowledgement that potentially there are places where reimbursement, not just on the commercial side, but broadly isn't sufficient. So
okay.
I think I understand your point. And I do think that I can incorporate some edits that I think would reflect what you're getting at.
Remember that you're doing this in the context of regulating commercial prices, which in and of it, some states are looking at that. Vermont is about to cut a bunch of services and potentially close 4 hospitals because of that. So there are causes and effects here, and that's direct cause and effect. So I think we just need to be in that context. That's how people will be reading.
Yeah.
And
And I think
it's important to acknowledge that price is the biggest driver of this premium increase. Just met with the Bureau of Insurance not too long ago, and they said that price drove 2/3 of the premium increase.
Yes, and I'm not disagreeing with that. I'm just saying we need to reflect that a bigger picture about what's driving prices.
Sure.
Because it's commercial prices, right? So I appreciate that labor is here. Jeff identified a number of other issues, and I'm just saying, even beyond those other issues, there's also that gap between Medicare and Medicaid payments being the oldest and one of the poorest states, and meeting our bottom lines, and therefore that drives prices as well.
Yeah, I think that's fair. I mean, to Meg's point, there's a whole laundry list of things that are driving prices. It's not just that you're increasing, or hospitals are increasing prices because they want to increase prices, right? There are underlying drivers there, and maybe it does make it a bit more open-ended to reflect.
Yeah, that's just all I'm saying.
Yeah, it may have even been that I just went too far in talking about workforce. Honestly, it's just because I just think that consistently that has been what
Absolutely.
folks have told me is the biggest challenge, and the most sort of acute now. And I think it's one where there's a very direct connection to patient access.
Yep.
Whereas with other things, there may be more ability to change models. But I think the workforce is one that, I put in only because I thought it was reflective of the feedback that I received.
It
But
is.
again, I would just say, I
It's
think that I'm trying to drive towards, what you said, Katie, which is that I don't want to say to people just,
This is-
prices are too high and we need to pay, we want to be thinking about how are we better supporting where there's not enough support, even as we think about prices as an issue in terms of the insurance, kind of pass through in the consumer experience. So just to briefly say next steps on this too, because I also wanted to be clear, it's not problem statement and direct to action. I think this aligns well with some of the work that we already, think is helpful, because again, I think that this also relates to sort of questions that I've heard about from legislators who are trying to wrap their heads around what's happening in our healthcare system and what can be done. So thinking about magnitude of impact on unit prices and premium increases, as I said, I think we hear that feedback sort of anecdotally, but we'd like to take a look at rate review and rate filings where there is actually sort of per unit and utilization information to do our best to kind of quantify that to help draw a clearer line, because I know, again, Katie, something you've brought up is thinking about like insurance costs over time. But I think that will help to make that conversation a little bit more concrete for everyone. Something we've talked about before as well are analyses of price and utilization that we've done just for hospitals globally, but trying to be more granular in those to look at geographic and service level trends, which we haven't been able to do, and to include non-hospital services. We've started with hospitals just given size and sort of making the analysis a little bit more digestible and simple for us to perform, but we'd like to expand that, because I do think in thinking about this component of where our price is high versus where our price is low, having a broader view that's outside of hospital services is really important. And then looking at hospital audited financial reports that are submitted to MHDO to think about this input cost issue and see, look at the data in terms of what's happened with share and payer mix in hospitals, but labor cost to sort of, again, we have these conversations, but trying to think about how do we develop work products that bring more clarity and can be informative to ourselves and to legislators in terms of making those arguments or giving them some insight. Are there other thoughts about maybe additional next steps we should consider, or these and analyses?
The analyses make sense to me. Question, do you plan to look at other states as well that have taken steps in this direction?
I
In
think,
terms of what they use for data or how they.
yeah, I would say in terms of using data and understanding that, I think we've got a pretty good sense. Katie and I talk to other states and are part of some work groups and things like that. So have a pretty good sense of, who's using their APCD for what, who's collecting ad hoc data, and how are they representing it. So, I mean, frankly, some of the analyses that we've done, I think, are pushing, the frontier a little bit. This is a kind of a new scope for work, but I do think we have a good sense of best practices. And one example is Katie in particular, but I was participating in it before she was. There's been a lot of work across states supported by the Commonwealth Fund, I think is the funder for that, around aligning around common terminology for some of these drivers. It's really, especially pharmacies, a particularly challenging one, but for other services too, how we think about things like how we define utilization, or at what level are we grouping by DRG versus CPT code, like the really technical stuff. So yeah, I think we're pretty keyed in on that. And on several of these, we also collaborate really closely with Karen Lee and MHDO. They are the holders of the APCD data. It was their vendor who worked on the dashboards for us. So we're also able, which we're very grateful for, to capitalize on all the learning they've done and sort of their board's input on methodology. So yeah, not coming up with this on the fly.
And she has been, I just want to note, just amazing because she works collaboratively with us on those things so that I think it's a joint learning process. So I totally respect using her work and her methodology and how she gets there is helpful.
Absolutely.
Comment on this. This may already be built in what you're doing, but what extent is the difficulty? Well, you have the labor costs and the environment in general, which makes it hard to staff appropriately, makes it hard to find timely care. So does that lead to a compounding or secondary effects of fractured care? So urgent care or even ED use in place of PCP that results in inefficiencies, as well as delayed care impacts of delayed care. And we're certainly seeing what seems to be some evidence of that in 2024 with the 2020, our members prior to members that have been with us longer than a year. So at least since 2023, if not since 2022, they weren't nearly so expensive last year. It's just like a hockey stick. And so it's oncology, it's cardiac, it's the things that you'd expect. Then we have a heck of a lot of alcohol dependency and really the conditions that go hand in hand with that. So those are the kind of top three drivers that I'm seeing, and it seems to be compounded by the fact that we have these issues of underlying costs that face everybody in Maine in terms of inflation, in terms of labor. And so it's almost like a snowball. And trying to tease that out might be secondary effects. That's my view.
Yeah, volume, you're raising something. Volume has been out of control recently. And it's delayed. I think a lot of it is delayed care. So I wonder, I worry about using data from any time between 2021 or even 2020 and through 2024, because I think it's going to be so all over the place because of COVID. It really did create a lot of.
And it's hitting the individual market much, much harder than it is large group or even small group. And I don't know if that's just curiosity, like a happenstance, or if there's something to the individual market that they just have a harder time navigating. Everyone has a hard time. They have an even harder time.
I always think unwinding, Kevin, which I know you do too, but I wonder, but you said these are members who have been with you for a few years. So it's not new members coming in and an uptick, yeah. So I would love to, and I know we've discussed in the past the idea of at a high level being able to talk about something like how delayed care drives higher costs because of setting. I don't think there's any way to do that on like a global, statewide scale. I think if members of this group are interested and have proposals of a specific type of scenario that we could look at, it's potentially something that we could do. If there's a particular diagnosis or set of diagnoses or set of services that we could isolate and say, however many years ago did we see more of this happening in a different setting type, and now we see more of it happening, in an ER, let's say. So I'm really open to that, but unfortunately, though, I wish that we could answer that question writ large. It's just, I think, too big to ever be able to navigate in the data. But yeah, I'd welcome if there's something useful like that we could take a look at.
Other thing is when you're looking at the financial statements, making sure that the FEMA payments and things that are one time are reflected as one time.
Yeah.
Traveler costs. It really, you were doing this at a time, we're coming out of like the most unusual time anybody's lived through in this generation.
And especially, I mean, that is good to know, because I think I kind of thought 23, that should be post sort of bounce back. I know 21 and 22 were a little bit more challenging, but if there's still kind of a lot of volatility, that's helpful to know.
Yeah, like colonoscopies. I mean, it really, yeah, you're absolutely right. We're seeing that.
I did just want to clarify though, Kevin, because I know one example was oncology, and I'm sorry, I'm not remembering the other, but those shouldn't be, that shouldn't be utilization. I wouldn't think that would be driven necessarily by access, unless it's sort of like you feel like there's a chance there's higher rates of diagnosis. Now, I just wanted to understand a little bit if you're thinking that particularly there is a connection to access and what you're seeing.
But this is just my theory. But to the extent that people have a hard time getting into a PCP, and then they get the diagnostics, and then they get into the specialist, and then they get the treatment plan. All of these things, take time, and so scheduling out specialist visit 6 months right now. I mean, it's just the way. I mean, I think it's statewide.
So it may be sort of folks returning to care post-pandemic, and that you didn't see the impact as early as you might have expected to, because it took them so long to kind of go through and actually get a referral to a specialist for treatment.
And to get into the specialist.
Yeah.
That's,
Right.
yeah. And so I think it probably is primary care. It's the fact that we have such a dearth of primary care access in the state causes the first delay, which to your point, then just escalates to go down the pike. But that's a significant issue. And I think we're all working really hard to get people in now. So you suddenly have a lot of people who are getting their diagnostics, and it's more advanced. That's the other piece, is that, the cancer didn't get caught early enough. So it's more advanced, so it's more expensive. And that will level out over time, we hope. But
Jeff, I saw that you put your hand up.
Yeah, no, thanks, Meg. And I think, primary care, certainly a huge opportunity in the state of Maine. One of the data points we noticed a couple of years ago from our participation in the Medicare Shared Savings Program, we sort of, culled some data out of the public use files and pretty quickly identified that, sort of top performing ACOs, that those really kind of saving the most money, have a much higher rate of primary care than any of the ACOs in the state of Maine. So this isn't sort of a Northern Line Health thing or what. This is really kind of a statewide, to I think was Katie's point, right? We have a dearth of primary care. And that's where healthcare really starts, right? So, good, strong primary care is going to pay benefits all around.
Definitely. Okay, well, I will keep on moving to the next, but happy to come back to this conversation if others have thoughts. The next category was the provider market oversight and competition. And I know I touched on a few different sort of like lenses on this. It kind of encompassed a lot when we talked about the issue back in the summer and kind of the state work that fell into this. But I think in particular, over the last few months and after sort of learning more from other states, wanted to focus particularly on the private equity issue that we discussed back in the summertime. Have seen some new research coming out just about growth in private equity. And while it's certainly not, a blanket on all private equity firms, there is some evidence that it's pretty new given the changes, but that, there's generally higher prices, staff reductions, and mixed evidence on quality. Most shows either same quality or lower quality of care with these acquisitions, as well as I didn't try to find a way to phrase this here, but I think there's also the pathway of, the really aggressive tactics to get short-term return that can lead to situations like what Massachusetts saw with kind of asset stripping of healthcare facilities and really drastic outcomes. Certainly the exception to the rule right now, so I want to be clear about that, but concerning. And like I noted here, I think this is different in that certainly there's not private equity ownership of hospitals here and just less activity in Maine than in other states. But I have given more thought to risk here and thinking about whether it's a good time to think about mitigating risk and considering impacts and doing that kind of proactively rather than waiting for a situation where the state would potentially need to respond or want to respond. I will say, given that this is kind of such an emerging area, and I think really, admittedly, myself wasn't something that I worked on in the past. I think a lot of states have begun to focus more because of what happened in the Massachusetts case. Want to do some more thinking here. I think there's different concepts that states have explored and a couple that have been implemented, including in Oregon, they have a more sort of comprehensive healthcare market oversight program. So the next step here really for me is just reviewing and kind of doing a deep dive on some of those options potentially with this group. There's not a huge amount of data here, so I don't think there's a big kind of research component to do in the sense that I think part of the issue is it's hard for us to get a sense of what's happening in the state because there's just not a lot of transparency or kind of centralized data collection around this. But I think we can gather what there is and put that together and then kind of just take a look at what are options here that potentially could be worth taking to be kind of in a protective state on this. Any questions on this?
I would say I'm really supportive of some level of protective action. I think once private equity gets into the market, it's awfully hard to put that genie back in the bottle. Addressing the board becomes a real issue. And I have very serious concerns about the impact that private equity buying up our hospitals practices would have on access to care, quality of care, prices of care, really everything.
So I share that, and I wonder if we might. Part of this is around equity. Private equity doesn't. Equity of care. Private equity does not work in anything but a healthy population. Like the only way they make money, they strip out Medicaid, Medicare, and they are here actually in a very small way. They just bought a practice in Portland or a part of a practice in Portland. So I think that's supportive.
I think
Keeping our eye on this.
Yeah, oversight of additional mergers and acquisitions, even outside the private equity space,
Sure.
but just more consolidation, I think, may benefit from more state level oversight. It seems like the FTC has not done a great job challenging mergers and acquisitions over the last decade.
And you could look at we have the CON law for hospitals, but it doesn't apply to practices. So we do have a little bit there, but I don't disagree.
Yeah, I think what I've understood from some other states is a challenge could be that a particular strategy has come in and sort of purchase one practice and then begin to expand and sort of build market power, which can make it hard because the individual transactions themselves aren't the problem. It's for the compounding effect. So I will say, I think, again, that's part of what it makes it a difficult problem to solve for is there's a lot of different avenues, a lot of different entities involved, but we would be really happy, and I'm glad to do a deep dive, maybe even now between now and our February meeting, and come back with sort of a review of what other states have done in a discussion.
Have you seen any data from other states who have like attorney generals who approve mergers and acquisitions, this kind of stuff in terms of like what they deny, what they?
The one example I know of off the top of my head is Oregon's healthcare market oversight program, which has been in operation for a few years at this point. They have not actually denied any transactions from what I understand. What they have done is apply restrictions on them. So they have the power to approve, but essentially with caveats. So things like you cannot do any service closures without our consent for a specific period of time. So those they've certainly done and had some significant back and forth with providers over, but have not outright denied any.
I have just anecdotally seen a bunch of articles recently that indicate that they're starting to pull out of healthcare. They're realizing that
You can't make money in this industry.
it's not a,
Maybe this
it
was-
doesn't
wasn't
follow
so
the
easy
5-year
after all.
turnaround model.
Yeah. Well, that's good to know. Yeah, I would love if it isn't a problem that we need to face, but.
I think it's worth.
Well, we will definitely make that short term to do. We've sort of started that, but just felt a little premature for this conversation, so we will get back on that. May have some conversations with some of the folks in the space in state government already too, and just see what they're thinking and their level of openness. So then the final category that I'd identified, and then I still have a slide on workforce to go, is aligning incentives to promote efficiency and quality. Hoping that this is not too controversial a problem statement. You know, I think generally see a lot of promise in kind of trying to think about how payment can actually align to the outcomes that we want to see instead of being on a fee-for-service basis. And that there has been progress on this, but at least, you know, my sense from my work in the state over time is like there have been challenges to really going to the next level and moving outside of, you know, some isolated models with certain payers or with certain practices, but not others, and getting to a place where kind of value-based purchasing achieves its goals because it's significant enough to actually drive changes in how care is delivered. So that's sort of what I tried to capture here. Maybe I'll pause there and see if folks have any comment on just the problem statement. Great. Good.
I do think that this is really particularly important when we're talking about primary care.
Yeah.
That's one of the areas.
Yeah,
Totally agree.
I'm happy to add a reference in there too. And I will also say, I should have said at the top, you know, for some of these, as usual, it's like there's areas of overlap, right? I think there's relationship to this and the problem statement and price too, and maybe one is a solution to another. Like they're not totally discrete and individual, but I found it helpful to define them separately.
Maybe have one go right after the other.
Okay.
Because I mean, this is sort of a solution that I think you're not going to have the same kind of concern related to as pure regulation of price. This is a broader solution.
Yeah, I'm happy to rearrange. Maybe lead with the private equity that's a little more narrow, digestible. Can get bigger and bigger as we go. So for next steps here, this has been something that's been on my mind for a while and that I have chatted with some other states about a little. I think I've mentioned before that there's really specific language in the statute establishing the office about monitoring the adoption of alternative payment models, which I think we fulfill in the sense that, you know, we talk to folks regularly, have a sense what's going on, but it's really challenging to actually know, you know, when I talk about progress on this front, like we don't have a good sense of here's the percent of payments that are being delivered through these models. So understanding we don't want anything highly burdensome. I would like to think about, I think a few states do have kind of a regular survey that they do to try and get a sense of that, or if there's other ways that aren't too burdensome for folks where we could have a more structured way of kind of keeping a finger on the pulse here, just as a sort of baseline level of work in this area. Another sort of category of work that I think relates and could feed in is, I've also mentioned before, thinking about the quality and access metrics. I think that thinking about what we mean when we say quality is helpful. And I understand very much that in particular payment models, you are going to want a very specific set of quality metrics, you know, if it's a bundled payment for a certain procedure. But I think at a baseline level, think about like broadly for the health system, what do we consider quality would be really helpful. So it's something we've mentioned before. Katie has been doing a little bit of work there, and in the new year, want to come back with kind of a landscape review of what's in use today, because again, also really do not want to reinvent the wheel here. I think we're thinking about what are metrics that people are already reporting in various ways, and could we just bring some of them together? And then the third, the most sort of significant scope of work, and I've mentioned this also at a high level, I think in prior meetings, but the idea of finding a way to have focused conversations about this with a group of leaders in the state that I think is inclusive of government and providers and insurance carriers and purchasers. So that we can think and sort of maybe get on the same page about what are the barriers here. I know, you know, Kevin and I were chatting, and I was saying there's different perspectives about what are the biggest barriers from different kind of players in the space or different entities in the space, and being able to talk about if we can identify a few of those, are there actually ways we can collaboratively work together to solve for them, as well as having an opportunity, and this is something that came up among folks talking about the AHEAD model from CMS, course, never know what will happen at the federal level, but some states have been successful in sort of working collaboratively and bringing feedback to CMS, not necessarily a totally unique model, but there are sometimes opportunities to engage with them early when they're designing models and to have some degree of influence in how they're structuring those that can make it easier or more difficult for states to participate. So I think I see that as something where, again, I think the department has, great leadership and thinking on this, and the Maine Care team do as well. But it's sort of outside, they're not necessarily bringing in commercial payers or working with them in a structured way. So creating a framework and a way to do that on an ongoing basis, I think, could be potentially valuable or at least worth exploring. So that's sort of what I'd envision for next steps here.
And when you say government, I would assume the superintendent of insurance is the primary person.
The superintendent, but I think Maine Care as well. Definitely thinking about the Maine Care team and folks from the public purchasers, I think having them at the table.
Yep.
I think more thoughts here on structure. So this is another where I'd love, like with sort of broad sign off on thinking about this direction, maybe coming back to this group with here's what we think the composition of that could look like and how to structure it and getting feedback there. It's still an early idea, but would want to cast a fairly wide net.
If I just would offer, we have, and I'm sure Kevin's aware of this, an experiment going on at Maine Health where we are investing in a primary care practice for our own employees initially as a pilot that is purely capitated. And so it would be, so if anybody, it's 2 months into the actually seeing patients, but we might be able to learn something from that model. So happy to bring the rock star woman who's running it to present at some point, and that would be helpful.
Yeah, it would be great. I had heard, but I think before it was actually up and running.
Yeah, I think it was just
Yeah.
about to be up and running.
Great. Jeff?
Yeah, no, thanks, Meg. So I won't comment on structure because I'm not much of a structure guy. But I will say, I think to your earlier point, a lot of work has been done in this area already. And so I would be cautious that sort of, we don't replow the field, right? There's a lot of good understanding of, what, some of the quality metrics ought to be, and there is more agreement than disagreement on the levers to pull to make value-based care and alternative payment models work better. So we're not starting from ground zero. I guess that's my point here, and really utilize the work that's been done now for over 10 years with Medicare, with Maine Care, and other payers that have, worked in this area.
Yeah, absolutely, Jeff. I will say, certainly not to imply that, this is something we need to go back and talk with DHHS about, but, Lisa Letourneau is somebody I've talked to over time, as well as Michelle and Olivia with Maine Care. So definitely give them credit for being a lot more in the weeds and keyed in on sort of some of the history and the work that's been done to date. So would envision them and hopefully you and others who have been at the helm of that work participating. I totally agree. I'm by no means looking to reinvent the wheel, and actually just recently was looking back at some of the sim work that was done. So I think that there could be some similarities, but at the same time, it just felt to me a little bit like maybe in more recent years, there hadn't sort of been infrastructure for that kind of collaborative thinking, and that potentially it had been, enough has sort of changed and there's been shifts in the landscape that it felt like a good time to maybe not think of it as the beginning of a new conversation, but just bringing a little bit more structure to conversations that already happen, again, to make sure that we're not always needing to be responsive to models that are being released by the feds, for example, that there's this a little bit more of an ability to come together and make sure we're on the same page about goals that we're driving towards, know the work that's happening, and again, can maybe problem solve a bit more collaboratively. The final slide that I had was on workforce. This had come up during the last conversation as potentially an additional domain to think about. And I have, done some thinking about this, and I think the short version of what I wanted to represent here was just, from my perspective at least, it feels like there's a lot of work that's been happening and is happening on this, including especially, DHHS having a position that's really focused on healthcare workforce development, and a lot of the investment that happened from kind of recovery funds. And so it's not to say that I don't think workforce is very important, and part of the reason that I wanted to reflect it specifically in some of the other domains as sort of a consideration or an element that we would have to think about with policies addressing those other domains. But I struggled honestly to see what would a role for our office be, or where are there, gaps, particularly I think in the policy space, as opposed to maybe some of the kind of operational coordination components that others who are a lot more read into this work and involved in this work historically, either aren't or couldn't be doing. So it's really brief, but yeah, just outlined some of what I know has either happened or is still currently kind of available in this space, and wanted to open it up and see if I'm missing something, or if, again, there are gaps that any members of the council think that we should go back and consider that the office could potentially fill.
I think I may have been the one who raised this initially. And I think when I was thinking about it, it was related to workforce as a driver of cost for us. So what we don't have here or I didn't see it clearly identified, is what are the cost drivers at the foundational level that are then being reflected in prices, that are then resulting in higher premiums. And so if that is if those cost drivers are in your mind somehow captured in one of these areas, I don't see this office as necessarily resolving the workforce crisis that we're in, but certainly acknowledging it, and how it is. It's both on the affordability level. It's a workforce crisis in terms of people being able to afford healthcare at one level, and workforce crisis in terms of providers being able to hire people at another level. So it's definitely ubiquitous in terms of how it's impacting the problems, the big problem statement that this office is charged with addressing.
Yeah.
And the changes in that over the last 5 or 6 years are dramatic. And I think that we need to make sure that gets reflected somewhere.
Yeah, I'm very glad to make sure that that's considered in a contextual way, but that is helpful to know, because I think I wasn't sure or had interpreted that needs to be one of the spaces that we're focusing on for work. And again, not that I don't think it's a problem that needs to be solved, but just that I felt like I don't think that we're necessarily the best positioned agency to kind of.
Nor do I think necessarily that the DHHS is. I mean, they have a piece, but labor has a piece. The fact that we just passed a new law that, for better or for worse, is going to cost every employee 0.5%, and every employer who is 15 or more employees 0.5%. I mean, there are lots of external forces at play here that definitely add to the affordability problem that need to be looked at.
Yeah, it's a challenging one. I know we've talked about that too, but it's such a broad issue. And yes, a health policy one in terms of its impact, but not necessarily a health policy question in terms of solving the problem itself. So yeah, okay, that's helpful. I just wanted to check that and make sure that sounded good to everyone.
But that was just me. Others, it's just me.
Anybody else? Thoughts on that? I think that was my last slide for today. I know I mentioned the annual report, but we do have annual report. I'm working towards a facility fee report. That one may, I suspect, come a little bit later. We're kind of gonna coordinate with MHDO around release of their updated one. But I will work to get drafts of those out to advisory council members. We'll probably need a little bit of a tight turnaround, but aim to give everybody a week to look at those if they'd like to, now that there's extra hands to help me with drafting. We're a little more ahead of the ball than we were last year. And yeah, we'll be looking forward. I think we'll hopefully, I would assume, be invited to come and give an orientation to the committee sometime in January, which will be the first one for the office given our start time. So we'll plan to probably track that pretty closely to the annual report with the caveat. I think some members of that committee had mentioned last year, and the office received a letter about revisiting the public option report at that point too. So depending on their focus, it may be that they ask us to kind of walk through that and report out a little bit more detail there as well. Any other items? Oh, one more. I knew I had one other admin. We do have one member of the advisory council who has a conflict at this recurring time next year. So I think we'll stick with this time for February, definitely, but may need to work through adjustments or just kind of navigating that. So that's the reason we haven't sent calendar invites for the remainder of or for all of 2025. But we'll get that February one out to folks in the next few days to hold that time, and may send a note around kind of polling timing. So just a FYI on that. Anything else from members? Great. Well, thank you, everyone. I hope everyone has a wonderful holiday season and start to the new year. And we will, I'm sure, be talking before then. But yeah, the next regularly scheduled meeting will be right at the beginning of February. So we will be in the depths of session once again already. So thanks all. Have a good one and see you again soon.
Thank you. Everybody have a great holiday.
Thanks.